I'll continue on the week before the exam series, and we'll do some random scenarios today, starting by the anatomy. So we have the esophagus. The esophagus begins at the lower border of the cricoid cartilage at the level of C6, and it will end at T11 after passing through the esophageal opening in the diaphragm. The blood supply, arterial and venous, and we need to mention the lymphatic drainage as well. The arterial blood supply, we're going to classify this upper third, middle third, and also lower third. The upper third is from the inferior thyroid artery, and the middle third, the aortic branches, and the lower third will be from the left gastric branch of the celiac trunk. The venous drainage will be upper third, middle third, lower third as well. Inferior thyroid vein, which will go into brachiocephalic vein, and then you have the azygos vein in the middle third, and the lower third will be the left gastric vein into the portal vein as well. On the other side, we also have the lymphatic drainage of the esophagus. It will go mainly to the deep cervical lymph nodes and the mediastinal lymph nodes and the gastric lymph nodes as well. So that's esophagus. Muscularis externa, and the upper third is a striated muscle, and the lower third it's a smooth muscle, and in the middle third it's a combination of striated and smooth muscle. The cell types in the esophagus, it's non-keratinized, stratified squamous epithelium. Defined Barrett's esophagus, it's a columnar metaplasia of the stratified squamous epithelium in the lower third of the esophagus with presence of goblet cells, and this does increase the risk of adenocarcinoma. The achalasia, it's one of the motility disorder at the lower esophageal sphincter, lead to increase in the lower esophageal sphincter. So that's the definition. Characterized by increased lower esophageal sphincter, failure of relaxation of this lower esophageal sphincter, and finally there will be dysphagia characterized by achalasia as well. The microscopy, you will find absence of myenteric plexus and failure of relaxation of the muscles with hypertrophied muscles as well. The sites of esophageal constriction, that will be the cricoid cartilage and the left main bronchus and the aorta or the aortic arch, and also the left atrium and the diaphragm at the end. Complications of esophageal perforation can lead to mediastinitis. The last rib in the mid-axillary line is the 11th rib. And then the stomach, we need to identify this, and these are the parts of the stomach, the fundus, and also you have the body, and this is the pyloric canal here, and first part of the duodenum at 23. Then what are the parts of the stomach? We just mentioned them. And the blood supply of the stomach divided into arterial blood supply and venous drainage. The arterial blood supply will be the left gastric artery coming from the celiac trunk, and the right gastric artery from the hepatic artery. And then the left gastro-epiploic artery, this is a branch from the splenic artery. And the right gastro-omental or gastro-epiploic artery, this is branch from gastroduodenal artery. And also the short gastric arteries from the splenic artery as well. The venous drainage will follow the arterial blood supply and will drain into the superior mesenteric vein and portal vein at the end. Or of course, the splenic vein as well, and then portal vein at the end. Yeah, that's the blood supply. You can go back to the video if you want to revise the explanation for that, but here we're just answering questions. In the duodenum, what is the peritoneal coverage of the duodenum? The duodenum is mainly retroperitoneal organ, except the first part, which is completely intraperitoneal. And then the blood supply of the duodenum is supplied by many arteries. I'm thinking of the one is the supraduodenal artery, which is a branch from the gastroduodenal artery, and then the superior pancreaticoduodenal artery, and then the inferior pancreaticoduodenal artery from the superior mesenteric artery. And you can also have branches from the splenic artery as well. You can give it some branches. And you have the right gastro-omental artery as well. So you have superior pancreaticoduodenal and inferior pancreaticoduodenal and supraduodenal artery. The venous drainage will follow the arteries and will go into superior mesenteric vein, splenic vein, and portal vein at the end. Relations of different parts of the duodenum. I think I've answered this multiple times before. You can just go back and revise that. All right, but maybe I'm going to mention the important two, which is the first and second part. The first part related anteriorly to the quadrate lobe of the liver and also the gallbladder, and superiorly is related to epiploic foramen, and inferiorly related to the head of the pancreas. Posteriorly is gastroduodenal artery, portal vein, and also the common bile duct. All right, so this is the first part. The second part is related medially to the head of the pancreas. Laterally is related to the ascending colon and the hepatic flexure of the colon as well. And posteriorly, the kidney, the right kidney, of course, and also the right psoas major muscle as well. And that's posterior. Anterior will be related to the transverse colon and the coils of the mesentery, the coils of ileum and jejunum as well. And of course, will be related to, not sure if there's anything else anteriorly, but of course, yeah, there will be the right lobe of the liver and the gallbladder as well. So that's anterior. And then you have the right kidney, right renal vessels, I did mention that, and the right psoas major muscle, head of the pancreas, ascending colon, and right colon flexure. Well, third and fourth part, you can just go through them, but I think the important one is first and second. It's quite a long question to be asked, and you'll be answering for at least 1 minute, so I think they will try to test you on different areas instead. The major duodenal papilla, it drains the head of the pancreas, upper part of the head and the neck and the body and tail, and it opens into the major duodenal papilla, which opens in the posteromedial part of the second part of the duodenum, and is 10 centimeter away from the pyloric antrum as well. The spleen next, we need to identify these impressions. As we can see here, D is the tail of the pancreas, and we have A is the renal impression, the left renal impression on the spleen, and also B will be the colic impression, and C is the gastric impression on the spleen. Okay, and of course this is the hilum, the fatty area at the hilum on the spleen as well. What is the blood supply of the spleen? The arterial blood supply will be through the splenic artery, which is a branch from the celiac trunk and will enter through the hilum of the spleen, and the venous drainage will go through the splenic vein into the portal vein at the end. The related reps is 9, 10, 11. Structures to worry about during splenectomy is the tail of the pancreas. Causes of a splenic course of splenic artery, it's a branch from the celiac trunk, and it will take a tortuous course just behind the stomach and on the upper border of the pancreas, and they will give blood supply to the pancreas as well, and then will enter the lienorenal ligament and then into the hilum of the spleen, and they will give multiple terminal branches, around 4 branches in the spleen, and will give the short gastric and the left gastro-omental artery as well. The spleen normally palpable, it's not palpable, and it will be palpable if it's twice as much as its normal size. In the supine person, what part of the abdomen is most dependent? It's Morrison's pouch. What clinical significance does this have? So Morrison's pouch could be accumulation of fluid, intra-abdominal fluid, and can lead to an abscess formation. So it's quite important to be aware of that. Through which layers the surgeon will cut during the midline laparotomy incision to be through the skin and subcutaneous tissue, scarpus fascia, linea alba, transversalis fascia, and finally the extra-omental fat, and finally the peritoneum as well. Right? Okay. The liver next. So we have here, need to identify a few structures on this side of the liver. So of course we have B at the left lobe of the liver, and A is the right lobe of the liver, E is the gallbladder, C is the that's the quadrate lobe, and then G is the falciform ligament, and H is the fissure ligamentum teres, and then we have D as the caudate lobe, and F is the inferior vena cava. We have, this is the I, G, and K will be the that's the porta hepatis, and will contain the I is the common hepatic duct, and J is the portal vein, and K is the hepatic artery. I would just like to revise a few things in here for I, J, and K specifically. So I common bile duct, J is the portal vein, and K is the hepatic artery, which is correct. And then we have D as the caudate lobe, and the quadrate lobe as C. Maybe G is falciform ligament, and H ligamentum teres. Let's see, falciform ligament and ligamentum teres, of course. So we need to identify a few structures here as well. So as we can see, maybe we can do it just randomly. We have 9 as the gallbladder, and 21, this is the caudate lobe, sorry, the quadrate lobe, 21, and 2 is the caudate lobe. 17 is the falciform ligament, and as a continuation, that would be fissure for ligamentum teres. 16 on the other side, that would be fissure for ligamentum venosum, and it will continue, as you can see, around the porta hepatis and the lesser omentum as well. You have in the porta hepatis, so 23 itself is porta hepatis, 5 is the common hepatic duct, 11 is the portal artery, 20 is the portal, 11 is the hepatic artery, and 20 is the portal vein. Okay, and then maybe 13 is the inferior vena cava as well. Okay, so these are the structures on the liver. What separates the right and left lobe of the liver? So anatomically, they are separated by the fissure for ligamentum teres and ligamentum venosum, and also falciform ligament anteriorly. But functionally, they are separated into two lobes as well, by the groove for inferior vena cava and also the groove for the fossa of the gallbladder, as you can see here. Okay, boundaries of the quadrate lobe, and I think we'll mention that a little bit early. So inferiorly would be the inferior border of the liver, and the gallbladder on one side, the fissure for ligamentum teres on the other side, and superiorly would be the porta hepatis. Structures in porta hepatis, you have the portal vein, the hepatic artery, and the common bile duct or the common hepatic duct. Two structures to be affected in this tab to the epigastric region would be the stomach and also the left lobe of the liver. Blood supply of the liver, 75% of the liver will receive its blood supply from the portal vein, which is partially oxygenated blood. The oxygenated blood will come primarily from the hepatic artery, which is a branch from the celiac trunk, of course. The venous drainage will go through the inferior vena cava, and all the lobes will drain into the inferior vena cava by coming together, except from the caudate lobe, which directly drain into the liver. Okay. Ligament support in the liver, we have multiple ligaments that will include ligamentum teres, ligamentum venosum, falciform ligament, lesser omentum, coronary ligaments, which and also the triangular ligament. Triangular ligament are right and left, coronary ligament are upper and lower coronary ligament. I think that's everything. What is callus triangle? Callus triangle is a triangle that's bounded by the cystic duct and also the common hepatic duct and the inferior border of the liver. It contains the cystic artery and part of the hepatic artery as well. It's very important clinically to identify this triangle while doing cholecystectomy to avoid injury of the cystic artery and the hepatic artery as well. So these are the boundaries: cystic artery and the hepatic artery. I didn't mention the right branch of portal vein as well. And these are the boundaries: cystic duct, hepatic duct, and finally the inferior border of the liver. Epiploic foramen, it's a foramen that represents the inlet or the entrance point to the lesser sac, which is behind the stomach. And this foramen is bounded by the quadrate lobe superiorly, first part of the duodenum inferiorly, and also anterior will have the free border of the lesser omentum, and this will contains the artery, basically the hepatic artery. And posteriorly, I think would be inferior vena cava posteriorly. Let's see. Yeah, inferior vena cava posteriorly. And we say the caudate lobe and the inferior border of the liver. And finally, the free border of lesser omentum and the first part of the duodenum. Contains the free border of the lesser omentum, contains the portal vein, common bile duct, and right hepatic artery. Okay. The finger can be inserted into the epiploic foramen and is squeezed against the thumb anteriorly. This is called Pringle's maneuver and is quite good to, of course, what structures are squeezed would be portal vein, hepatic artery, and common bile duct. What is it used for? To stop the bleeding and the laceration of the liver. The gallbladder next. The surface margin of the gallbladder, it will be the 9th costal cartilage mid-axillary line. Sorry, mid-clavicular line. All right, just lateral to the linea semilunaris. What are the causes of shoulder pain in cholecystitis? So basically, in acute cholecystitis, this will lead to irritation to the central part of the diaphragm, and the sensation of the central part of the diaphragm is conveyed through the phrenic nerve, which has the origin of C345, and the supraclavicular nerve had the same origin as well, so that's why the pain will be radiated to the shoulder. Let's identify a few structures in here. First of all, this is an ERCP, retrograde cholangiopancreatography, that was done endoscopically. A, we're talking about the ambula of Vater, and B, this is the main pancreatic duct. C is the common bile duct, H is the common hepatic duct, G is cystic duct, F is the neck of the gallbladder, E is E will be the body of the gallbladder, I believe, but I would be unsure about D. So it's either E and D at the body of the gallbladder. And finally, we have I and J. That would be the hepatic ducts left and right. So let's see E and D. So E is gallbladder, and D is the fundus of the gallbladder. So yeah, basically E will be the body and D will be the fundus of the gallbladder. And these are the parts of the gallbladder. Where does the common bile duct enter the bowel? It enters in the through the ampulla of Vater by forming the ampulla of Vater with the main pancreatic duct, and enter through the major duodenal papilla, which is 10 cm away from the pyloric antrum. Anatomical structure that control bile secretion, that will be the sphincter of Oddi. In the pancreas, the parts of the pancreas, this onset process, head, neck, body, and tail. Cell groups, these are alpha, beta, and delta, secreting glucagon, insulin, and somatostatin consecutively. The blood supply of the pancreas, it will take from superior and the inferior pancreaticoduodenal artery, also from the splenic artery as well. The venous drainage will follow the arteries and will end up into splenic vein, superior mesenteric vein, and then portal vein. The ducts of the pancreas, we have two different ducts, the major and minor pancreatic duct. The major duct will drain the part of the head, neck, body, and tail. The minor duct will drain through the onset process and lower part of the head. We'll talk about the development later on. The vessels encountered during Whipple's procedure, that will be the abdominal aorta, superior mesenteric artery, and the pancreaticoduodenal arteries as well. We also have veins, that will be the superior mesenteric vein, also the splenic vein, and then portal vein, in addition to the left renal vein as well. Let's see. Great. Vessels ligated in Whipple procedure, that would be the right gastric artery, I believe, right gastric and right gastroepiploic arteries. Ligaments connecting with the spleen, that's the lienorenal ligament and gastrosplenic ligament. Embryological development of the pancreas, that will develop from the hepatic diverticulum, and that will give the ventral part or the ventral bud, which will arise from the hepatic diverticulum, and that develops the lower part of the head on the onset process and the accessory pancreatic duct. The duodenum will give the dorsal bud, and this will develop the head, neck, body, and tail, and also the main pancreatic duct. Let's identify 3 and 9 here. We have 3. This is the head of the pancreas. 9 is the neck of the pancreas. Maybe you can say 14 is the superior mesenteric artery, and 15 is the superior mesenteric vein. Maybe you can talk about 10 will be the right colic artery, and 7 will be the middle colic artery, and maybe 4 that will be the ileocolic artery, and 5 these are jejunal branches to the jejunum, basically coming from the SMA. 16, for example, on the top right, on the top left, 16, that will be the tail of the pancreas, for example. Okay. Cool. Appendix next. Position of the appendix. Appendix typically presented as a retrocecal organ. This is the commonest site, around 67%. However, it can pre-ileal, post-ileal, and also, retrocecal is the commonest, but can be retrocolic, pre-ileal, post-ileal, and pelvic appendix as well. So retrocecal is the commonest, all right? But we can have subcecal, pelvic, and pre-ileal, post-ileal, and so on. As you can see here, these are the sites for the appendix. Cool. The blood supply of the appendix, the artery will come from the appendicular artery, which is a branch from the ileocolic artery, and is found in the mesoappendix, and we need to worry about that during doing the dissection by the laparoscope. The venous drainage will be appendicular vein, which will go to the ileocolic vein, and finally will drain into the superior mesenteric vein up to the portal vein at the end. Let's identify 2, 4, and 15. So basically, 4 is the cecum, and 2 is the appendix, and 15 is the terminal ileum. Maybe 11 is the sigmoid colon. Also, 3 is the ascending colon. Okay. All right. Well, yeah. 12 is the mesoappendix, and we said 15 as well. Great. Urinary bladder. What is the blood supply of the urinary bladder? So the blood supply will be the artery. That's the superior and the inferior vesical arteries, and these are from the internal iliac artery. The veins will go to the venous plexus, and that will be the vesical venous plexus, the internal iliac vessels or veins. The nerve supply for the dorsal muscle, it has sympathetic from L1 and 2, and that will cause relaxation to the wall and contraction to the sphincter. And also parasympathetic will go from the sacral region, and that will cause contraction to the wall and relaxation to the sphincter. But the sympathetic will cause relaxation to the wall and contraction to the sphincter. To be honest, I don't remember what I said, but sympathetic cause contraction to the sphincter and relaxation to the wall. Yeah. And parasympathetic will be from S2 to 4. The constant cancer types in a urinary bladder, we have adenocarcinoma, transitional cell carcinoma, squamous cell carcinoma, or mixed types. The common presentation of urinary bladder cancer, that could be painless hematuria. The risk factors of bladder cancer, smoking is a very high risk factors, nitrosamine containing, and also some rubber dyes and schistosomiasis as well. Aniline dye as well can lead to a risk factor. Well, ureteric orifice, it opens in the posterobasal part of the bladder on the trigone, which is at the corners of the urinary bladder. The peritoneal coverage is basically covered from the superior surface only. The suprapubic catheterization layers will be the skin, subcutaneous tissue, scarpus fascia, then linea alba if we're doing it in the midline, and then after that will be the extraperitoneal fat. But of course, we're not going to puncture the peritoneum, will be the bladder directly. What are the posterior relations of the bladder? So in a male and a female. In a male, that will be the rectovesical pouch. In a female, that will be I think will be pouch between the bladder and the vagina. I think so. So it's called female vesicouterine and the uterus, right? Vesicouterine pouch. You missed that one. Cool. Let's identify here a few structures. Okay, so we're gonna go to the big structures first. So of course 18, which is down there, we have the urinary bladder. Okay, and then 16, this is the uterus, body of the uterus, and 15 is the fundus of the uterus. On both sides, you have the fallopian tube, which is I think 10 on both sides. Okay, and then you have the round ligament as number 9 on the right side. And then we need to identify 7 and 15, okay? So 15 is not actually pointing to the fundus of the uterus. 16 is just the uterus. But 15, it's a pouch. And 17 is another pouch. So we have a pouch between the urinary bladder. And 17, this between the urinary bladder and the uterus, that would be the vesicouterine pouch. And then 15 will be Douglas pouch or rectouterine pouch. If we go up in the image, we have 12 at the abdominal aorta, 11 at the inferior vena cava, and then that will make number 6 as the left common iliac artery, and we'll make on the other side the 5 at the right common iliac vein. What else we can identify here? All right. Maybe you have the psoas major muscle as number 3, and of course it's present there on both sides. I think an important structure is 2 on both sides. If you try to identify this, I think that would be the gonadal vessels on both sides. To check the answers quickly, we said 7 is, I didn't say 7 actually, so 7 is the ovary on both sides. Fallopian tubes is, I think will be, can't see really, 8. Yeah, so 8 would be the fallopian tubes. And 15 is, like we said, that will be the rectouterine pouch or Douglas pouch. 17, that will be the vesicular pouch, and we said that correctly. 18 is the bladder. I think 10 will be the round ligament of the uterus. That's why it's going to the canal, as you can see here, the inguinal canal. And 6 on both sides. So 6, you have this is the common iliac on both sides, coming from the abdominal aorta. All right, and 18 is the bladder. We said that. So yeah, I think that's pretty much it for this one. There are other things that I said. You can check the answers as well. That's the kidney. We need to identify a few structures. So G, this is an impression for the adrenal gland. And A is, we're talking about the kidney itself. We're looking from the posterior surface of the kidney. And we have D as the abdominal aorta. And E is the inferior vena cava. C, that looks like the renal artery. And B is the renal vein. And F is the ureter. And we need to identify which side of this. So I did not say left or right. So all of that would be the left-sided kidney. Okay. So we said this is left kidney as A, and then these are the structures, as you can see. The organs related to G, this is the left suprarenal gland or adrenal gland. Usual order of the structures, it will start from the ureter posteriorly, and then the vein, and then the artery as well, as you can see here. See, the vein is the most anterior, I believe. See that? So yeah, renal vein is the most anterior, and then artery and the ureter. This even clarifies that. So you can see the ureter at the most posterior structure, and then you have the artery and vein. Again, we said that this is left side, not this one, of course, but we said the one above was the left-sided kidney. At what level does this organ lie, and what its fascial structure? So usually to start from T12 to L3. And of course, the one on the left side is a little bit higher than the one on the right side. So it will take 3 levels. Okay. The posterior relation of this organ or the kidney, it's related to the diaphragm, the psoas major muscle, also the quadratus lumborum muscle as well, and the transversalis muscle. Okay. This organ, intraperitoneal or retroperitoneal, it's a retroperitoneal organ. And lymphatic drainage of this organ will be the para-aortic lymph nodes. The upper pole as well will go to the mediastinal lymph nodes. Okay. Then we can go to the skull and histology. We said this many times. I'm just going to go through it very quickly. When do the cranial sutures ossify? That would be at the age of 18 to 24 months. Name one condition which cranial sutures diffuse at birth. It's called craniosynostosis. And then age of development of mastoid bone, that's 2 years. Diploic vein, these are veins between the inner and outer table of the skull and drain into the dural venous sinuses. The pterion is formation by 4 bones, frontal, parietal, temporal, and the sphenoid bone as well. Clinical significance, it represents an approach to access the circle of Willis, and also on the inner side of the pterion, the meningeal artery passes, and it's responsible for the epidural or extradural hematoma. Layers of bare holes at the pterion, we said this multiple times, that would be skin, subcutaneous tissue, and then you have the aponeurosis, can be there, and the temporal fascia, temporalis muscle, and the pericranium at the end. The source of subdural hematoma, these are cerebral veins and the bridging veins as well. Styloid process and muscles attached to it, that would be styloglossus, stylopharyngeus, and the stylohyoid muscle. Sphenoid sinuses, let's identify them here. This is 1 is the frontal sinus, 2 is the sphenoid sinus, 3 is the maxillary sinus, and 4 is the sphenoid sinus. 2 is the ethmoid sinus. Okay, from the external surface, we need to identify a few openings. I'm not going to say the contents. I think I covered this multiple times. 10 is foramen magnum, 3 is the carotid canal, 20 is the jugular foramen, 11 is the foramen ovale, and that's of course on the right side, and 12 is foramen spinosum, and 47 on the other side, that would be stylomastoid foramen. The contents, just to revise them, I said this multiple times, you can refer back to the videos. In this one, we need to identify a few structures as well. We'll start from the front. 1 is the anterior cleanup process. 38, this is the sella turcica. 45, that would be the tuberculum sella. 8, dorsum sella. 4, the clivus. 11, foramen magnum. 27, hypoglossal canal. 30, this is the right jugular foramen. And 28, this is the right internal acoustic meatus. And you have 12, this is the left foramen ovale. 14, this is the left foramen spinosum. 13, this is the left foramen rotundum. And 34, this is the left optic canal. And 42, this is the right superior orbital fissure. Maybe 43, this is the left tegmen tympani. And 41, this is the squamous part of the temporal bone as well. 21, this is the superior part of the petrous part of temporal bone. Again, the contents, you can revise them or refer back to the previous videos as well. Anterior cranial fossa, I think I covered this many times again, and then the boundaries and the content, and the middle cranial fossa, it's quite important and came multiple times, so maybe just to revise them as well. I'll skip this for now. Well, the clivus is related to the abducent nerve, and it's a juvenile structure. Forming it is called the spheno-occipital synchondrosis. Synchondrosis is a hyaline cartilage. Time of fusion 12, 13, 14, 15, and 17, 18. So 12, 13, that starts in girls. 14, 15 starts in boys. And 17, 18 will complete the fusion. Benign tumors in the posterior cranial fossa, ependymoma and acoustic neuroma. Okay, base of a skull fracture, this is a posterior transverse transsphenoidal skull fracture. Lytic lesion in the skull could be metastasis from anywhere apart from the prostate. That could be the breast, and also the thyroid gland and the kidney, and maybe multiple myeloma as well. Paget's disease, hemangioma, sarcoidosis. Then we have the femur as well to revise, and that will be the important bit. To identify these structures, we have number 4. Of course, this is the left-sided femur. On this one, the one is number A. We're looking from the posterior surface. So 4 is the head of the left femur. 11 is the neck of the left femur. And we have 12 is the quadrate tubercle. And 5 is the intertrochanteric crest. 8 is the lesser trochanter. And 3 is the greater trochanter as well. So to identify the structures attached to 3, that will be the piriformis muscle, gluteus medius and minimus, obturator externus and internus as well. 8 will have the iliopsoas muscle, or the iliacus and the psoas major muscle as well. Okay, so these are the structures, the important structures, and then we have the lines. Maybe 9 is the linea aspera, and 11 is the neck, we said that, and the quadrate tubercle has the quadratus femoris muscle. This one, 3 is the head, 1 is the fovea, and you have 11 is the trochanteric fossa, and 4 is the intertrochanteric line, 8 is the quadrate tubercle, and 5 is the lesser trochanter, and 2 is the greater trochanter as well. Okay, 10 is the spiral line, I believe so. Yeah, and 11 was heterochanteric fossa. 8 is the quadrate tubercle. This one, that's the distal part of the femur. So in A, we're looking from anterior, and B, we're looking from posterior. So 1 is the adductor tubercle, 9 is the medial epicondyle, 8 is the medial condyle, 11 is the patellar surface of the femur, 5 is the lateral condyle, 6 is the lateral epicondyle, and 7 is the lateral supracondylar ridge, and 10 is the medial supracondylar ridge. Same structures in here, and these are the answers. Muscles attachment. So first of all, I would like to go to the greater trochanter, which is very obvious here. So you have 10, this is the piriformis muscle. And you have 4 and 5. 4 will be the gluteus medius, 5 is the gluteus minimus. 11, of course, is the lesser trochanter, the left femur, and attachment is iliacus and psoas major muscle. Maybe we can get a little bit down from this surface. So you have maybe 1, this is adductor brevis, 2 is adductor magnus, 3 is gluteus maximus as well. I think these are the main things which I have here. I believe this is a very important dissection, and not only for the muscle attachments, but also for the femoral triangle, which you have it here with the boundaries and the content as well. So let's start by that one. So we're going to start by number 4. This is the external oblique aponeurosis on the left side. From now on, all the structures are on the left side, so I don't have to say left every time. So that's 4, inguinal ligament and the external oblique aponeurosis. 19 is the sartorius muscle, and we have 26 is the tensor fascia lata, 5 is the fascia lata, and 12 is the iliotibial tract. We have 17, this is the quadratus femoris muscle, 29, this is the vastus medialis, 28, this is the vastus lateralis muscle. 19 looks like the sartorius muscle, of course on the left side, and 1, this is the adductor magnus muscle, and you have 15 as the pectineus muscle, and 11 as the iliopsoas muscle. So I think now we identified all the muscles in this dissection. If we go to identify a few of the vessels, you have number 6 as the femoral artery, and 8 at the femoral vein, and then you have 10 at the great saphenous vein. Okay, a few veins on the top quite close to each other. So you have 24, this is the deep external pudendal vein, and 23, this is the superficial external pudendal vein, and 22, this is the superficial epigastric vein. Okay, and so number 7, for example, this is the femoral nerve, and you have number 18 at the saphenous nerve as well. Maybe 13 as the inguinal ligament all the way around. 21 is this looks like the spermatic cord coming out from the superficial inguinal ring, or maybe 25 a superficial inguinal ring, and 21 that's the spermatic cord coming out for it. Let's check that one. Yeah, 21 is spermatic cord, 25 the superficial inguinal ring. All right, so these are all the structures in here. Maybe we can just revise the attachments of rectus femoris muscle. It comes from the anterior inferior iliac spine, and it will go to the ilium, the superior to the acetabulum. And then 28, the vastus lateralis, it comes from the greater trochanter to the lateral lip of linea aspera. And also the vastus medialis muscle, 29, enter trochanteric line and go to the medial lip of iliac crest. Cool. All right. Another very similar dissection is starting by the C, which is the inguinal ligament. We have F as the femoral vein, and of course we're on the left side, and G is the great saphenous or long saphenous vein, E is the femoral artery, D is the femoral nerve, B is sartorius muscle, and A is the adductor longus muscle, and that's the boundaries for the femoral triangle, which contains the D, E, and F, the femoral artery, vein, and nerve. And we also have H as the gracilis muscle, like we said, B is the sartorius muscle, and L is vastus medialis, I is rectus femoris, and J is the vastus lateralis, and on the top, K is the tensor fascia lata. What's the origin and insertion of the psoas major muscle? It arises from the spinous process of T12 to L5 and the vertebral bodies in between, and also the vertebral disc in between as well. It attaches to the lesser trochanter of the femur muscle, and it's not supplied by nerve supply of the femoral nerve, which is L1 and 2, and the anterior rami of L1, 2, 3. Let's see the answer. You see here. The iliotibial tract attachment, from the name, it arises from the ilium, part of the ilium, and the supraacetabular fossa, and will attach to the lateral condyle of the femur. The name tibial is mentioned because it gives some extension to the tensor fasciae lata down to the tibia as well. And its function and its usefulness as iliotibial tract would be related to the tibia as well, which we're going to mention now. So the function, it gives attachment to two muscles, which is the tensor fasciae lata and gluteus maximus muscle. And it extends the tensor fasciae lata down to the knee, which lets it act as abductor and external rotator as well. It will also give support to the knee in extension and partial flexion, and this will give us the ability in biking and running and so on. So ilium, supraacetabular fossa, lateral condyle of the femur, as we say, gluteus maximus and TFL, and finally the clinical significance. It stabilizes the knee in extension and partial flexion, allows the TFL and the gluteus maximus muscle to support the knee in extension while standing, running, walking, and biking, and also extend the TFL muscle into the lower thigh and the leg, allowing it to function as an abductor. The gluteal region, we have number 3 is the coccyx, and 10 is the gluteus maximus, and 18 is the tensor fasciae lata, and then 4 is the anal canal, 5 is the adductor longus muscle, and 11 is the iliotibial tract, and then here 17 is on the lateral side, and this will be the biceps femoris muscle. 26, that's a nerve, the most superficial in this diamond shape, the popliteal fossa, that would be the common peroneal nerve. 24 is the tibia nerve. 22 is semimembranosus, and then 6 is semitendinosus. Then you have gracilis as number 23, and also the sartorius as number 21. You have 25, that's the medial head of the gastrocnemius. 28 is the lateral head of the gastrocnemius muscle. The gluteus maximus origin, it arises from the sacrotuberous ligament and from the gluteal side of the ilium, just posterior to the posterior gluteal line, and inserted into the iliotibial tract, supplied by the inferior gluteal nerve. That's very quickly the origin, insertion, nerve supply of the gluteus maximus muscle. The action, it basically extends the hip when it's semi-flexed, and also steadies the hip joint as well, and act as one of the lateral rotators of the hip joint. Okay, then the sciatic nerve. Starting by the surface anatomy of the sciatic nerve, it's between 2 points. First point is halfway between ischial tuberosity and the greater trochanter, and the second point is between the ischial tuberosity and also the posterior superior iliac spine. So it's a line connecting between those 2 points in the gluteal region. What is the course of the sciatic nerve? So it exits the pelvic cavity through the greater sciatic foramen, mostly inferior to the piriformis muscle, as a single nerve formed of the common peroneal nerve and tibial nerve as well, and surrounded by a connective tissue sheath. However, and also it continues all the way down, just posterior to the adductor longus muscle, adductor magnus muscle, and deep to the piriformis muscle, the biceps femoris muscle. Yeah, so posterior to adductor magnus and also deep to the piriformis muscle, or the biceps femoris muscle, sorry. Variations, regard sciatic nerve exiting the pelvis. The commonest route will be the sciatic nerve leaving as a single nerve formed of the common peroneal and the tibial nerve, together surrounded by a connective tissue sheath just inferior to the piriformis muscle. And some variations around 12% of the patients, you will have the common peroneal nerve penetrating the muscle and the tibial nerve inferior to the piriformis muscle. In other variations, quite rare, 0.5%, the common peroneal will be superior and the tibial nerve will be inferior to the piriformis muscle. Let's see the answer. So 1 will go together below to or inferior to the piriforms. 2 and 12% tibial nerve and the inferior border of the piriforms, and common peroneal at the superior border. And then the rarest variation, so the common peroneal nerve will be superior, and also the other one will be inferior, the tibial nerve. As you can see here, the common peroneum sometimes penetrates and the common peroneal sometimes be above, or they come together basically, simply as that. What is Trendelenburg sign? It's one of the signs that happens due to paralysis of the superior gluteal nerve, which supplies the gluteus medius and minimus muscle, which are the abductors or the epiductors of the hip joint. A positive sign is when the patient stands on the affected side and the pelvis will start to fall down, of course, from the affected side. It happens sometimes with patients who have a space-occupying lesion in the pelvis, or maybe pelvic fracture, and also those with posterior approach to the hip surgery. Of course, the patient gait will be affected as well, and it's named as Trendelenburg gait as well. So, epiductal paralysis, the patient stands unsupported on one side, and the hip will start falling down on the affected side. It happens due to damage of the nerve, the superior gluteal nerve, pelvic fracture, space-occupying lesion, and also hip surgery.